which dangerous substances cleaning and just explaining the concepts. And abrasives, they are substances which mechanical cleaning, scoring, scrubbing action, grinding, rubbing, and scraping action. So these are called as abrasives, and there can be finishing abrasives, polishing abrasives, or abrasives. Can be many types of abrasives. There are also anti-plaque agents, and this question had come on the exam a few days ago, few semesters ago. So there are antimicrobial agents, there are plaque removing agents, and there are agents which pharmacology identifies abrasives and anti-plaque agents. I advise you to go to the details of the chapters. There are more things to come. Styptics means the local hemostatic agents, and there's fibrin, thromboplastin, thrombin, fibrinogen. This is one group of drugs. They are all related to blood. Then there are vasoconstrictors like epinephrine, which produces local hemostatic action. It decreases the blood flow, and that's why we combine epinephrine with local anesthesia. Then there are astringents, which can, because of the astringent action, they can stop the bleeding. And there are other drugs called as gelatin, tranexamic acid, and ethamserate. So prepare a short note on styptics. Disclosing agents, they help for visualization of plaque. And the most commonly used is erythrocin, then there is fluorosin, and there are also two-tone dyes available. Drugs used for xerostomia is the dryness of mouth. This usually is produced due to radiation treatment and also produced in a condition called Sjogren syndrome. And sodium carboxymethyl cellulose and oxidized glycerol triester are the commonly used drugs. And as you know from your autonomic nervous system, cevimeline, oxotrimorin, and these are the drugs which are used for treatment of xerostomia. Obtendants are most important because they decrease the sensitivity of the exposed dentin. And examiners are fond of this question. They ask you, mention, they have to decrease the sensitivity of the exposed dentin. So one, they can destroy the nervous tissue, or they can straightway paralyze the sensory nerve ending so that you don't feel the pain. And the third way to do it is to precipitate the proteins from odontoblastic fibrils. I hope you know that precipitation of proteins means astringent action. And this is why astringents are extremely important. They can stop the bleeding. They can also produce obtendant effect. So prepare about obtendants. And if you have done your dental pharmacy practicals well, I reducing agents, and there is chlorinated lime, and there are also ultraviolet rays. So most important here is hydrogen peroxide and sodium thiosulfate. As far as mummifying agents are concerned, they are useful for hardening or drying of the soft tissue pulp and the root canal. So they mummify. Mummify means they dry, they harden. They fix the pulp. So pulp becomes resistant to the entry of bacteria. So you use it during pulpotomy, and when the pulp is revitalized. And most important substance here is formaldehyde, and you cannot forget this tannic acid. You already prepared an astringent gum pen. Look at this. I was talking about astringent. I said that astringents can be useful in number of ways. So this is one more way. Astringents can be not just styptic agents, they can also be mummifying agents. Next, astringents. We are coming to this astringent proper. What is the definition of the word astringent? They are going to ask you. Is precipitate the superficial proteins. Astringents precipitate superficial protein. When you precipitate the superficial protein, it forms a layer, and in this layer, the bacteria can get absorbed. So they are not just astringents; they are also adsorbents, and they form a protective layer through which the noxious substances, the bacteria, the food cannot enter, and whatever ulcer is below this, that ulcer gets a kind of protection, and it leads to an ulcer healing effect. And as we just now said, it can produce styptic action, that is, it can stop the bleeding, and it can also produce drying effect. Astringents also decrease edema and inflammation. So there are a number of conditions in which we use astringents. Gingival ulcers, bleeding gums, aphthous ulcer. You can see many conditions here. And again, I am highlighting this tannic acid, which is present in catechu, tincture catechu. Catechu is kat in Marathi. So remember about astringents, they are important drugs. And after dental pharmacology, I take you to a very interesting system, and we will have a quick, rapid, and beautiful revision of autonomic nervous system. After passing out BDS and after passing out MBPS, years after that, if the friends meet and if they talk about pharmacology, most of them they say, वो क्या एंटीकोलिनेस्टेरेज एंड एंटीकोलिनेस्टेरेज कुछ समझ में नहीं आता is the Hindi word, never understood what is that. So I will not make you say it, you will definitely understand it. Try to pay attention. I'll be a little bit quick, but we'll do a nice session on autonomic nervous system. First, I'll tell you what are the adrenergic receptors. I'm not here to tell you all the things which are written in the book. You already read it, you already studied it, your teachers have already taught them. Now, we are here just to quickly revise the most important things which must be remembered. That's the must know. So there are two types of adrenergic receptors, beta and alpha. And the beta receptors are beta 1 and beta 2 receptors. And wherever I'm showing an upward arrow, that upward arrow means the receptor is stimulatory. The receptor is excitatory. For example, beta 1 receptors in the heart is excitatory, means it's going to stimulate the heart. It's going to increase the force of contraction. It's going to increase the rate of contraction. It's going to increase the cardiac output. Beta 1 receptor in the kidneys is responsible for release of renin. And when renin will be released, finally, there will be angiotensin, and this will lead to vasoconstriction, and this will lead to increased blood pressure. So these are all sympathetic or adrenergic receptor actions. Beta 2 receptors, as opposed to the beta 1 receptors, look at the downward arrow, are inhibitory in nature. So when you stimulate the beta receptor, the bronchus gets relaxed. So that's opposite effect. I hope you will remember the beta 1 receptors in the heart and kidneys are stimulatory, but the beta 2 receptors in the smooth muscle of the bronchus, also smooth muscle of the uterus, are inhibitory in nature. So if you stimulate beta 2 receptors, there is bronchodilation. If you stimulate beta 2 receptors, there is uterine relaxation. And the most important, beta 2 receptor in the liver is responsible for breakdown of glycogen and gluconeogenesis. So this is going to increase the blood glucose level. Alpha 1 receptor, the most important site to remember of alpha 1 receptor is peripheral blood vessels, small blood vessels in the periphery. And this receptor is excitatory, upward arrow. So that's going to lead to vasoconstriction, and this is going to increase the blood pressure. And the radial muscle of iris is also an excitatory receptor. The radial muscle of iris contracts, but because it contracts upside down, the inside out, that's why there is dilatation of the pupil. The pupil dilates. So these are important adrenergic receptors. Now, based on these adrenergic receptors, we will have a look at the adrenergic agonist and adrenergic blockers. First, the adrenergic agonist. Agonist means stimulants. And you know the catecholamines and non-catecholamines, epinephrine or adrenaline and norepinephrine or noradrenaline, isoprenaline, dopamine, dobutamine, and the non-catecholamines, ephedrine and amphetamine. You have been spoken a lot about these drugs during your throughout your entire year. The next group of drugs, adrenergic agonists, which are more commonly used now, are the selective adrenergic agonists. They won't stimulate all the alpha and all the beta receptors. They will have a selective action so that their toxicity will be comparatively less as compared to the non-selective adrenergic agonists, which are shown above. So the first group is bronchodilators. They are called as selective beta 2 stimulants, and they are salbutamol, terbutaline, and long-acting like salmeterol and formoterol. The second group is nasal decongestants, which act on alpha receptors, and the alpha receptors in the nasal blood vessels. So there will be constriction of the blood vessel because alpha receptor is stimulant, and this is how there will be a decongestant effect. Phenylephrine and whatever nasal decongestants you commonly use are usually xylometazoline and oxymetazoline. Then there are vasopressor amines, which will act on the peripheral blood vessels and which will stimulate the alpha receptor, and this will lead to vasoconstriction and increase in the blood pressure. So sometimes in conditions of hypotension, you might use the three drugs. You can see that all three starting with M: mephenteramine, metaraminol, and methoxamine. And lastly, uterine relaxants, which are also called as tocolytics. Tocos is childbirth. So uterine relaxants are the drugs isoxaprine, nilotrin, and ritodrine, and they'll be used for prevention of premature labor. So these are the most important drugs for which will relax the uterus and which will not contract the uterus, allow the uterus to contract and produce abortion or produce premature delivery. So uterine relaxants are isoxaprine, nilotrin, and ritodrine. So that's about adrenergic agonist. And now we discuss the blockers. I'm not going to discuss alpha blockers on this session. We'll discuss only beta blockers. And beta blockers are non-selective, which block beta 1, beta 2, both the receptors. For example, propranolol, nadolol, timolol, most important. And there are drugs which are cardioselective, which preferentially block beta 1 receptor. And there's minimal action on beta 2 receptors. They are called generation 2. And they are more commonly used: atenolol, metoprolol, bisoprolol, etc. There are drugs which block beta receptors as well as alpha receptors. So they are called combined alpha beta blockers. And most important drug from this group is labetalol, which can be used in pregnancy, and carvedilol, which is extremely useful for heart failure. And I have added last group of beta blockers here because they are commonly used in this condition. Beta blockers used in glaucoma. They decrease the intraocular pressure mostly by decreasing the aqueous humor secretion. And the commonly used beta blockers in glaucoma is timolol, betaxolol, levobetaxolol, and levobunolol. So all these are available as eye drops. So that's a very gross classification of beta blockers. Now, since we spoke about beta 1 receptors and beta 2 receptors and where are they present, we are talking about the adverse effects of beta blockers. And I hope you realize that they block the beta 2 receptor in the bronchus, which will lead to bronchospasm and precipitation of bronchial asthma and COPD in susceptible patients. And in the liver, it's going to produce hypoglycemia unresponsiveness, which is going to be harmful in diabetes. Why this is happening? Because wherever you have hypoglycemia, your liver is supposed to break down glycogen and bring glucose to the blood. And we saw that that action is responsible due to the beta 2 receptors. Now you block the beta 2 receptors, so this breakdown of glycogen is not going to happen, and your body is not going to respond to hypoglycemia. And hypoglycemia can very commonly happen in patients with diabetes who have fluctuating blood sugar levels. And this is why beta blockers should be avoided as far as possible in patients with known bronchial asthma or patients who already have diabetes. Although the cardioselective beta blockers are less likely to have these effects, but the selectivity is never absolute. And this is why it is better to avoid beta blockers in patients with bronchial asthma and patients with diabetes mellitus. Next, beta blockers do produce hyperlipidemia. They produce fatigue and mental depression on long-term use, and they also produce sexual dysfunction. And you cannot stop beta blockers abruptly. If you stop them abruptly, then because you have given the blockers, there is likely to be upregulation of the receptors, and because of the abrupt stoppage, the epinephrine and norepinephrine, which is inside the body, will start acting on the upregulated beta receptors, leading to precipitation of angina and very severe increase in the blood pressure. So please remember most important adverse effects of beta blockers. Beta blockers I chose for today's topic because still beta blockers are extremely important drugs, and we are going to revise the uses. And my way of remembering them is first say about 5 conditions which are cardiovascular. Number 1, hypertension. Number 2, chronic prevention of angina pectoris, chronic prophylaxis of angina pectoris. We combine them with nitrates. Next, chronic prevention of myocardial infarction. Not only this, we also give beta blockers in acute myocardial infarction, and we use beta blockers for supraventricular arrhythmias, supraventricular tachycardias, because they mostly act above the ventricle. So these 5 conditions first remember, and you are done with most important conditions in which beta blockers are used. Next, as I remember, beta blockers decrease anxiety, and they decrease the symptoms which appear due to anxiety. The symptoms due to anxiety are tachycardia, palpitation, and so on and so forth. So thyrotoxicosis is one condition, and most of the anxiety states we use beta blockers. In the same way, when the patient is withdrawing from alcohol or any other drugs, drug withdrawal states, anxiety is the most common symptom. So now I remember three conditions, four conditions which are related to anxiety. And finally, I go on to remember migraine, chronic migraine, pheochromocytoma, and glaucoma. So look at this. If you do it this way, you get 5 plus 2, 7 plus 3, 10. 10 uses of beta blockers. That's the way to remember. Now we go to cholinergic receptors. And as you know, they are muscarinic and nicotinic. Again, I have that style and fascination of doing upward arrows and downward arrows. These receptors, the neurotransmitter is acetylcholine. And naturally, in the heart, it is suppression. In the smooth muscles, we need acetylcholine for contraction. Naturally, upward arrow, respiratory tract smooth muscle, gastrointestinal smooth muscle, and gastrogenitourinary muscle. Exocrine glands, we need acetylcholine for secretion. And in the eye, acetylcholine stimulates the sphincter pupillae to produce meiosis, means constriction of pupil, and it stimulates the ciliary muscle of lens for accommodation. And as you already know, at the nicotinic receptor, the skeletal neuromuscular junction, acetylcholine is the neurotransmitter. So this is the nicotinic receptor. And now we will see what are the drugs which stimulate cholinergic receptors and which block the cholinergic receptors. You can have drugs which directly go and act on the cholinergic receptor. And these are called directly acting cholinergic drugs, carbachol, bethanechol, methacholine. But fortunately or unfortunately, they are not commonly used now. They are toxic. Whereas there is cevimeline, pilocarpine, and oxotrimorin. If you remember, I mentioned these drugs for treatment of xerostomia. Yes, because they increase the secretions. They are like acetylcholine, so they will increase the secretions. And the next group of drugs, more important, is indirectly acting drugs. Indirectly means what? Means they are anti, read it carefully, anti, I made a hyphen, CHE is cholinesterase. So these are the drugs which inhibit the enzyme cholinesterase. So when the cholinesterase enzyme is inhibited, acetylcholine won't be broken down and it will accumulate. And this way, it will produce the effects of acetylcholine. So we call them cholinergic drugs. They are indirectly acting drugs. They are anticholinergic drugs. The reversible anticholinesterase drugs, first one is physostigmine, which is useful in atropine overdose and which is useful in overdose of many drugs, and very rarely it is used in glaucoma. The next one is, of course, neostigmine, pyridostigmine, which you have heard of because of myasthenia gravis. And there's a drug called idrophonium, which is short-acting drug and used always intravenously. And neostigmine and pyridostigmine, you might have remembered only for myasthenia gravis, but I want to tell you that after major surgery, if the skeletal muscles are relaxed and if you want to revive the skeletal muscles, which we call as reversal of neuromuscular blockade, that's also called post-operative decurarization, then these drugs are very commonly used. So that's neostigmine, pyridostigmine, and ambenonium. And for Alzheimer's disease, we use rivastigmine, donepezil, galantamine, because they try to concentrate acetylcholine. They try to concentrate the acetylcholine in the brain. They are cerebroselective drugs. So these are some important drugs which are indirectly acting anticholinesterase drugs and which are commonly used. Now I'm reminding you of the indirectly acting anticholinesterase drugs which are irreversible, which are organophosphorus compounds. And during your pharmacology, they have taught a lot about organophosphorus compound poisoning and how atropine is useful and how oxines are used. Everything you have done a lot, so I'm not going to discuss it. So I hope you have an overview of the drugs which act like acetylcholine on this page. Now we move on to cholinergic blockers. And when you want to block the cholinergic receptors, there'll be muscarinic blockers, that's atropine and atropine substitutes, and there'll be nicotinic blockers, which block the nicotinic receptor at the skeletal neuromuscular junction and will relax the skeletal muscles. So they are skeletal muscle relaxant, ditubokirarin, pancuronium, vacuronium, atracurium, etc. So all these drugs are nicotinic blockers. We are not going to discuss these on this session. We are going to concentrate on atropine and atropine substitutes. So I'm going to tell you the adverse effects of atropine. I hope you remember now that atropine blocks the muscarinic receptor sites, heart, smooth muscle, exocrine glands, and eye. So likewise, we will derive the adverse effects: dryness of mouth, dryness of the eyes, and dryness of the respiratory tract. And because of this, because it produces extreme dryness in respiratory tract, it's not useful in chronic obstructive pulmonary diseases, in bronchial asthma. So atropine is contraindicated in chronic obstructive pulmonary diseases. It's also not given to patients with extremes of age, too young patients and too old patients. Then eye, blurring of vision, photophobia, because it produces passive mydriasis and cycloplegia. So there is paralysis of accommodation and there is increased intraocular pressure. And this is why it's never used in acute congestive glaucoma. I hope you remember this. This is a very important condition. Next, urinary tract. It produces retention of urine and urgency of micturition. Naturally, we don't give it in benign prostatic hyperplasia or if the patient has any other condition which is going to lead to retention of urine. Atropine produces constipation and it stimulates the heart to some extent, so it leads to tachycardia. These are called classic muscarinic effects. So please remember them together: dryness of mouth, blurring of vision, retention of urine, and constipation. These four are classic muscarinic effects. And if atropine is taken in overdose, then atropine produces hyperpyrexia, there is loss of temperature balance, and there is delirium and coma. And the interesting thing, which is written in many books: dry as a bone because there is dryness, red as a meat because there is vasodilation, hot as iron because there is increase in the body temperature, blind as bat because there is blurring of vision, and mad as hatter because atropine produces delirium and coma. Atropine crosses the blood-brain barrier and produces effects on the central nervous system. And to treat this, we give physostigmine because it is an anticholinesterase agent, firstly, and it will revive acetylcholine at the muscarinic receptor. So it will have antagonism with atropine and it will remove atropine from the blocked sites. In addition, it will cross the blood-brain barrier and it will reverse the central actions, central effects of the atropine poisoning. And atropine can be used for number of conditions. If they ask you anytime uses of atropine, first say organophosphorus poisoning, and because it is a muscarinic blocker, say early mushroom poisoning and physostigmine poisoning, which we just now saw. Most important cardiac uses of atropine are sinus bradycardia, AV block, and digitalis induced bradycardia. When you start digitalis, you start getting bradycardia and you give immediately atropine if the heart rate goes below 50. Atropine is most important substance for pre-anesthetic medication because it produces decrease in the secretions and it prevents the bradycardia. These are two important issues, plus it relaxes all the smooth muscles. Next, it can be used as a mydriatic for eye examination, and it can be used alternatively with miotics to break the adhesions between the lens and iris. And atropine is, of course, antispasmodic because it relaxes all the smooth muscle of the gastrointestinal tract, of the urinary tract. So we can also use it for incontinence of urine and renal colic. Atropine is useful in Parkinson disease because of its effect in the brain, and it can be used with pyridostigmine or neostigmine, myasthenia gravis, to block their muscarinic actions. Because pyridostigmine, neostigmine, when used in myasthenia gravis, we want an action on the nicotinic receptor, on the skeletal neuromuscular junction. We don't want muscarinic effects, so we use atropine to block the muscarinic effects. To be clear, nowadays, atropine is used for selected conditions because we have better drugs. Atropine is non-selective. It acts on all muscarinic receptors, but we have the drugs which act on selective muscarinic receptor sites, and that's why we have the atropine substitutes. Look at the names and you will remember definitely. Antispasmodics, which are used for colicky pains, which can be used for peptic ulcer, is pirenzepine, which is a specific M1 blocker, and hyoscine butyl bromide and dicyclomine, most commonly used for acute abdominal pain. Then you have drugs used for urinary incontinence. Most commonly used is flavoxate and oxybutynin, and there are newer drugs which you can find in the book also. Then there are drugs which are bronchodilators. We said atropine is contraindicated in bronchial asthma. The reason was the dryness of the respiratory tract. But we have atropine substitutes which will produce bronchodilation like atropine, but the dryness will not be there. Is ipratropium bromide and tiotropium bromide, mostly used by the route of inhalation. Then we have mydriatic drugs which can be put in the eye. The mydriasis and cycloplegia with atropine can last for a very long time, for 5 days and 7 days. So we can use mydriatics like tropicamide cyclopentolate, which have got a shorter duration of action. Then we have drugs, hyoscine or scopolamine is available for motion sickness. It's available as tablets, it's available as chewable tablets, it's also available as a transdermal patch. And we have a uterine relaxant drug called valethamate. So this classification is extremely important. They can ask you classify atropine substitutes based on their mechanism of action or based on their uses, and you can do this clinical classification of the atropine substitutes. So we went to the adrenergic agonist and blockers, and we went to the cholinergic agonist and blockers. And I have something to tell you. Please prepare a classification notebook. Please start practicing classifications. Take a blank paper and start writing classification. If you don't remember, open your book, see what you're missing, and again try to do it. This is going to help you extremely well on all kinds of questioning and viva. Prepare a list of drug and antidote. I showed you how to prepare. This is also going to help you. And prepare a list of enzyme and its inhibitor. For example, anticholinesterase. So write the name of the enzyme cholinesterase, and the inhibitor is the anticholinesterase drugs, that's physostigmine, neostigmine. You will find almost 50 most important enzymes inside the body, which are extremely important pharmacologically, because you are going to derive 50 different mechanisms of actions and 50 different drugs which are inhibitors of the enzyme. So please do these 3 things, is going to be helpful to you. And everyone tells you solve the old exam papers. Everyone does it, I suppose. Important take-home message for examination is attempt all questions and write in the same order as they are appearing in the question paper. It will be easy for the examiner to know what you have written and what you have not written, and you are likely to score better if this happens. And write only what is asked. Don't write what is not asked. If you don't know, leave the question blank, but don't just put anything. Don't feel that examiners are in a hurry and examiners don't have time to read. They can just read your one page in a few seconds and they can understand that you have written whatever is not asked and not related to questions. So please take care of this. Go to MUHS learning website. MUHS has really done an innovation and it has published 104 videos. So you heard me today. Thanks for listening to me. You can hear more topics in more details. It takes you to YouTube. Go to YouTube and put MUHS learning and put MBBS 0 for pharmacology, and you will be able to see the videos. And there's a totally free website. That's my website, mutalikpharmacology.com. You can study with the help of this. I am very thankful to MUHS. I am very thankful to Dr.